We're coming straight from the textbook today, and the first exemplar that we're going to cover is going to be the peptic ulcer disease. It's found in your Iggy textbook on page 1096, and you automatically think of something being eroded and a lesion appearing, and that lesion becoming inflamed, maybe having some exudate and some secretions and some bleeding. Well, that's what peptic ulcer disease is. A peptic ulcer is an erosion of the mucosal lining of the stomach and the duodenum. The mucous membranes in those two areas, in the stomach and the duodenum, which is the first portion of the small intestine, the mucous membranes become eroded to the point that the epithelial cell lining becomes exposed to a lot of gastric acid and pepsin. When this occurs, it leads to bleeding, and it can also quickly lead to perforation. Perforation that extends through all layers of the stomach or duodenum can lead to peritonitis. What do you know about peritonitis? Is inflammation of the abdominal cavity. The peritoneal cavity is a sterile cavity, just like the bladder is a sterile environment. Anything that leaks into the peritoneal cavity is going to cause an overwhelming systemic infection, a life-threatening systemic infection. Same thing as with a urinary tract infection. The bladder is sterile. Anything that enters the bladder begins to infect it, and that's how people get urinary tract infections. So with many of these disease processes like peptic ulcer disease, if you're looking at appendicitis where it ruptures, or anything that ruptures and leaks into that peritoneal cavity will develop into an overwhelming systemic infection called peritonitis. Now, your textbook on page 1096 describes 3 types of peptic ulcers diseases. What type peptic ulcers are there?
Duodenal ulcers, gastric ulcers, and stress ulcers.
And stress ulcers. And many of these ulcers are caused by a H. pylori infection. This H. pylori infection can be transmitted from oral to oral route, or it can be transmitted from fecal to oral route. But the H. pylori in the bacterium, the H. pylori infection, it can burrow into the mucus layers of the stomach, and it can be fine where it doesn't cause any illness for some people. In others, it may cause peptic ulcer disease. And then in still others, H. pylori infection can cause gastric cancer. So that's the importance of being tested when you have GI issues, because you don't want that person to be one of that percentage that develops gastric cancer. Now, where do the duodenum or the duodenal ulcers occur in the stomach lining? Where do they occur?
The upper portion.
Okay. The upper section of that small intestine is correct. And those ulcers can be very deep. And remember, these are the ones that can penetrate and perforate and cause leakage into the peritoneal cavity. What is one of the main symptoms of the duodenal ulcer?
Pain when the stomach is empty.
Okay, whenever they have not eaten any food, their stomach will hurt. So they have some epigastric pain when their stomach is empty. What's another thing about it?
Pain that wakes you up in the middle of the night.
Okay. And they're going to have very low pH levels. What did you learn in your ABG class? A low pH level is what? Gastric or alkaline? Acidic or alkaline. It's very acidic. So inside the peritoneal or the duodenum, where that ulcer is located, there is lots of acidic secretions there that keeps that lesion sort of open and inflamed and irritated, where it can become inflamed and begin to perforate and penetrate the mucosal line. Okay? The other, gastric ulcers, where is it located?
Antrum of the stomach, your acids.
Okay, it's in the antrum of the stomach. And we know that gastric ulcers are caused by back diffusion of acid or dysfunction of that pyloric sphincter. If that pyloric sphincter does not open and close well like it should, then a backwash of the gastric secretions can go back into the lower end of the stomach and stay near that first portion of the small intestine, which is the duodenum. So that is one of the causes for gastric ulcers. All right. The next ulcer that we're going to talk about is the stress ulcer. Who gets the stress ulcers?
Nursing students.
Nursing students, but it's anybody that has been through a medical crisis or traumatic event. Maybe if they have developed sepsis, they've had a head injury, if they've been in ICU for a long period of time, the stress has been on the body. If they have had burns, extensive burns, they may develop a stress ulcer called a curling ulcer. If it's sepsis, they may develop some type of ischemic ulcer. And then if it's increase in the cranial pressure, they may develop a cushion type ulcer, but they all fall under stress ulcers. The body is stressed, and stress ulcers are associated with long-term hospital stay, and they have an increased mortality rate. So that's why when anybody has been in a trauma or received surgery, and it's going to be a long-haul recovery for them, you will see as a part of their medical treatment that they will be receiving IV therapies of a proton pump inhibitor to help prevent stress ulcer development. Okay? Now, let's talk about complications of ulcers. And this slide here shows you where the gastric acid is and the location of gastric ulcers as well as the duodenum ulcer. And again, this picture is just showing you the location for those areas where the ulcers will occur. Now let's talk about complication. What are the main complications from developing ulcers?
Hemorrhage, perforation, pulmonary obstruction, and intractable disease.
Okay, and so the most common serious complication from peptic ulcer disease is going to be hemorrhage. And it can occur in patients with gastric ulcers and in older adults. How will the nurse know that the patient is having upper GI bleeding in the abdomen? How will the nurse know that GI bleeding has occurred? Low H&H when you look at the CBC. But what's going to alert the nurse at the bedside? Coffee ground emesis, or it might be bright red since it's upper GI. The stools will become dark. Look on page 1099. They may have a decreased blood pressure because they may be bleeding out. Increased heart rate, so you're going to see vital signs that suggest shock and that the patient is bleeding. Weak peripheral pulses, they may be dizzy or lightheaded, or may become syncope where they lose conscious. That's how the nurse will determine that maybe this patient is having a complication of hemorrhage from the peptic ulcer disease. Okay? Another complication you said was perforation. How will the nurse know that the patient has probably developed a ulcer that has penetrated and perforated and is now leaking into the peritoneal cavity?
Sharp pain.
The pain in the abdomen is going to be like no other pain. It's going to be the worst pain that they've ever felt. But for the nurse, just simply palpating the abdomen is going to be very telling. The abdomen will not be soft. It's going to be board-like. You see how hard that wood is on that desk? It's going to be hard like that. The abdomen will be very board-like, hard. And the patient will feel apprehensive. The abdomen will hurt and be very tender. And it's all because they probably have had a perforation of their ulcer that has now developed into peritonitis. So that is a complication that the nurse is going to be monitoring for. How will the nurse know that a pyloric obstruction has occurred? What kind of symptoms will they be having?
Vomiting.
They're going to be vomiting. Symptoms of obstructive complication is going to be the abdominal bloating. They'll have nausea and vomiting. And when that vomiting persists, you're going to have that acid-base disturbance going on where they may develop metabolic alkalosis and they may develop hypokalemia from all of the vomiting or metabolic alkalosis that occurs. So pyloric obstruction, pyloric is that gastric outlet. When it is obstructed, then you're going to have nausea, vomiting, abdominal pain, but a lot of vomiting, and you're going to have acid-base changes. Okay? What is intractable disease? That's a complication. It may be due to stressors in the patient's life, or maybe they're not responding anymore to conservative management with the proton pump inhibitors, the H2 antagonists, all the medicines. They may just have recurrent episodes of peptic ulcer disease that fails to respond to any traditional treatments, or they may have a relapse. Okay? Now, what is the cause, the etiology? What's the cause for peptic ulcer disease? What causes it? A bacterial infection. So anytime that you're looking at gastritis or any ulcers that are abdominal ulcers, stomach ulcer, you're going to always think about H. pylori infection because it is the cause of many of the ulcers. What are some other causes for peptic ulcer disease? Long-term use of NSAIDs. And it's not only NSAIDs, long-term use of steroids, corticosteroids can cause peptic ulcer disease. The ibuprofen, any of those meds can cause peptic ulcer disease as well. Now your book takes you back to the gastritis chapter for some of the other risk factors, and these are going to be things like consuming a lot of alcohol or coffee, caffeine beverages, being under a lot of stress, if you're smoking cigarettes, or radiation therapy from cancer treatment, or if you have accidentally or intentionally ingested some type of corrosive substance can cause peptic ulcer disease. Now let's talk about the history. What type of questions are we going to ask the patient to find out, is this a peptic ulcer disease problem?
Current or past medical conditions.
Okay, it always starts with that patient history. And you mostly want to know, have they had any GI medical issues before? Have they had any problems with being positive for H. pylori infection before? Look at all of their medications that they're taking, even the over-the-counter medications. And you want to ask them about the corticosteroids, the chemotherapy, or the NSAIDs, okay? And then you want to ask them about any GI surgeries. Another thing is questioning them about how much alcohol are you drinking? How many packs of cigarettes are you smoking? And ask them, have they noticed certain foods like tomatoes that are acidic or caffeinated beverages, do they cause those abdominal symptoms that they're having? And does those type foods worsen the symptoms that they're having? And as someone said, the difference between the duodenum ulcer and the gastric, is there a relationship to the pain when they're eating? You want to ask questions about that. Now, what is that patient going to look like that has peptic ulcer disease? What will they look like? What will they be complaining of? Stomach pains. And where in their stomach? When we think about stomach, we think about here. But when we think about the abdomen, how many quadrants does it have? Okay, and then we got the symphysis pubic area there, and we got the epigastric up here. So where in the abdomen are they going to be hurt with peptic ulcer disease? Where's the stomach? What we call the stomach. It's epigastric. Epigastric. So they're going to have more epigastric tenderness and pain, and it shows you where it's located. And if it's penetrated, penetrated, and then it becomes perforated. What does perforated mean? Bulging through, that it has begun to leak. If it gets to that point, then what is that abdomen going to feel like for that patient? Board-like, rigid. It's going to be very painful. And it may be the whole abdomen, a diffuse abdomen pain and discomfort. What does dyspepsia mean? How is it described? Sharp burning or gnawing pain. Okay? Sensation of fullness. Pressure. Okay? So, what labs are you going to be concerned with monitoring if you suspect that the patient has peptic ulcer disease? There's 3 simple tests to detect that H. pylori. What are they? Okay, so you can test for H. pylori all 3 ways: their blood, their breath, or their stool. What else are you going to be concerned with? Their H&H. You're going to be looking to make sure that their H&H is within normal limits. If it's decreased, will you be alarmed? Would that be unsuspected?
Depends on how low.
Okay. Depends on how low it is, but if you think that they've got a peptic ulcer that may be penetrating and may be bleeding, then we would expect some mild or modest decrease. Okay? All right. Now, there are some other diagnostic tests. Your textbook talks about the esophagogastroduodenomoscopy. We call it EGD. That is the most accurate test because you can put it down and look directly into the stomach. And if you have that patient NPO, then they will be able to directly see the lesions in the stomach as well as that first portion of the small intestine. So the EGD allows direct visualization. There is a rapid urese test that can confirm a quick diagnosis because urese is produced by the bacteria, that H. pylori bacteria. So you can test for H. pylori that way as well. And then GI bleeding, if you suspect GI bleeding, there is a nuclear medicine scan that they can do. They give the patient a IV contrast medium, and then the GI system is scanned for the presence of bleeding. All right? What questions do you have about the ulcers themselves, the symptoms that will occur with peptic ulcer disease, and the diagnostic tests?
Sometimes they'll have like a decreased appetite too, right?
They will. They will. Because and it may be unintentional weight loss. They will lose weight. But sometimes, depending where the ulcer is, if eating triggers the pain, then they're going to be afraid to eat because they don't want to hurt too. So the appetite will be decreased. Well, let's talk about planning. What type drugs would you expect to treat the H. pylori with? PPIs, the proton pump inhibitors, and they're going to treat them with some antibiotics. And on page 1101, you will see what medications they're going to use. What's the common drug? Now, your book talks about the lansoprazole. I think that's the same thing as Prevacid. Let's see. Prevacid. It's the same thing as Prevacid. And they're going to add 2 antibiotics with it. It's a flagyl. They may use tetracycline. They may use clarithromycin and also amoxicillin. The patient will take these medications, all 3 of them, and sometimes it may be a 4th drug added, but it will always be some type of PPI in the antibiotics. They will take these medicines for 10 to 14 days. Okay? The drug that they may add may be the Bismol therapy. That's something very similar to the Pepto-Bismol. If they are taking aspirin already, you may want to caution that patient because the Pepto-Bismol also has aspirin in it, and you don't want them to take too much of it. Okay? Any questions about the meds that will be used? I want you to turn to page 1097, and you're going to see the meds. They will use a combination of H2 antagonists and proton pump inhibitors. What's the difference between the 2 of those? What's the difference? The H2 antagonist is going to decrease gastric acid secretion, so it's slowed down. And then the proton pump inhibitors are going to suppress gastric acid secretion. So it's suppressing and decreasing, so it works together to relieve the ulcer in the stomach or the duodenum of so much acid production being in contact with it. Okay? So what 2 H2 antagonist blockers may be used that's recommended? Famotidine, nizatidine. Okay? Those are the H2 antagonists. There is a mucosal barrier fortifier. It's called Sucralfate. This will protect the stomach mucosa because it will coat and line the stomach lining. It will coat and line. Coats the stomach lining. And then we've talked about the Bismol. And remember, you're going to remind that patient to refrain from taking aspirin. Okay, and then you have your proton pump inhibitors. The omeprazole is the same thing as Prilosec. The lansoprazole is the same thing as Prevacid. And then you have the pantoprazole, same thing as Protonix. And the esomeprazole is the same thing as Nexium. So these are some of the proton pump inhibitors and the H2 antagonists you will see ordered, along with 2 other antibiotics, and they'll have to take them till it's all gone to effectively eradicate the H. pylori infection. Okay, let's move along to the action alert. Who has their book open to page 1101? Read to us what the Nursing Safety Priority Action Alert says.
After EGD.
I forgot. You all just finished psych. Okay, you can go ahead and read it. Go ahead and read it.
After EGD, monitor vital signs, heart rhythm, and oxygen saturation frequently per agency protocol until they return to baseline. In
That's
addition,
the wrong box.
Oh, that's not
I'm
the right
sorry.
box.
I'll read this one. This is talking about teaching the patient with peptic ulcer disease to follow a healthy habits and avoid substances that increase gastric acid secretion. And remember, we've talked about anything containing caffeine, coffee, tea, cola. All of this should be avoided because coffee contains peptides that stimulate gastric release. So, what diet traditionally do you see people placed on whenever they have any stomach ailments? A bland diet, and it's going to assist in relieving some of those symptoms. And your textbook said food itself acts as an antacid by neutralizing some of the gastric acid for 30 to 60 minutes. If you can put in your mind's eye, when the stomach is empty, where is the gastric acid concentrated? On the ulcer lesion. But once food is introduced into the stomach, where is the gastric acid concentrated then? On digesting the food. So some people get some relief for a while after eating. Okay. So all of this that you've seen on TV that talks about eating smaller meals, like 6 meals a day, that's really not recommended by your textbook, but it does recommend eating a bland, non-irritating diet. With complementary and integrative health, what's suggested? Hypnosis. Anything that can reduce stress. She said yoga. Any emotional stress is thought to worsen a lot of GI disorders, such as peptic ulcer disease and irritable bowel syndrome. You'll see that stress will worsen those diseases. Now on page 1102, when we think about the analysis and the problems that the patient with peptic ulcer disease is going to have, there's 2 main ones, and they're here on the slide. Of course, they're going to have acute pain or persistent pain, and they're going to have that potential for upper GI bleeding, or the bleeding can be caused by the ulceration, the penetration of that ulcer, and the perforation of it. So that's going to be the main thing that the nurse is going to be concerned with the peptic ulcer disease. So how does the nurse take care of this patient? Go ahead. Pain relief and manage the bleeding. And you have a priority box that talks about critical rescue, that your priority for care of the patient with upper GI bleeding is to maintain that airway, breathing, and circulation, and respond to those needs by providing oxygen and ventilatory support, and starting 2 large bore IV lines for replacing fluid and blood, and monitoring their vital signs, their hematocrit, hemoglobin, and their O2 sat. So you're going to be concentrating on placing oxygen on that patient, starting IVs and getting fluids in that patient, and also monitoring their vital signs in their lab. Another intervention that you may see ordered by your physician is a nasogastric tube placement and lavage. They will insert the nasogastric tube and then they're gonna lavage it. It's just like they're put the tube in, they're gonna pour room temperature solution in volumes to 200 to 300 milliliters, and they're gonna let it drain back out. And they'll keep doing this until the return from out of the stomach is clear or light pink, and it doesn't have many clots. I can remember as a young nurse working at South Central Regional Medical Center on the second floor. That was their med-surg floor. And we had someone that came in with GI bleeding. They put the NG tube down quickly and connected to suction, and wow, can you imagine a GI bleed and the suction machine pulling all of that out of the patient? It was pulling it out of the patient, and the IV fluids were infusing fluid into the patient. And of course, that patient had to receive blood. But that is a way to lavage the abdomen or the stomach. Now, it's not necessarily that they will be connected to suction. It may be a matter of infusing it in and pulling it out with your plunger, lavaging the stomach. Okay, and then they're going to keep that patient on their left side doing the procedure. Why the left side? Is that the natural curvature of the colon and the stomach from the colon? Okay, but they'll keep that NG tube in for a few days, or it can be removed after lavage if the return is getting clearer and clearer. Okay? Now, sometimes if they have pyloric obstruction, again, they're going to put that NG tube in to decompress the abdomen. This time, the NG tube will be connected to low intermittent suction. And this is going to be to decompress the stomach, and then they will correct any metabolic alkalosis problems and any dehydration. All right, and then if the patient is still having complications, they can go in sort of like an EGD, and they can go through the endoscope and do a procedure to stop the bleeding. They can inject a chemical on the bleeding ulcer to stop the bleeding, or they can treat it with heat or electric current or laser to sort of cauterize the lesion from bleeding, or they can close that affected blood vessel with a band or clip to keep it from bleeding. Okay? All right. Then there are other radiologic procedures that can be done for those with upper GI bleeding. They can get an arteriogram that can find the exact location of the bleeding, and then the radiologist can inject a medication or some other material into the blood vessel to stop the bleeding. Okay? So this is just some ways that can be used to treat GI bleeding. We've already talked about drug therapy, and what did we say would be aggressively given and administered for H. pylori infection and peptic ulcer disease? What medicines?
PPIs.
The PPIs, the H2 antagonists, and the antibiotics. Okay. Now, what if they have to have surgery? What type surgical procedures are done? Used to be called a Bill Roth 1 and a Bill Roth 2, but your textbook now calls it a minimally invasive surgery. It's done laparoscopically, where they will go in and remove any chronic ulcer or treat any hemorrhage from a preparation. That's the type of surgery that is done. And the care is the same. You all know that if you're treated laparoscopically, the time in the hospital is shortened and lessened, as well as the side effects and complications are lessened. Okay, I do want you to look on page 1104. There's a self-management education. Do you see what you would teach the patient with peptic ulcer disease, the home care consideration? It's everything that we've talked about. You're going to assess their GI and cardiovascular status by monitoring their blood vital signs, their skin color, noticing for any pain, any changes in their bowel elimination. You're going to notice their hemoglobin and hematocrit, listen for bowel sounds, and palpate for any areas of tenderness. With nutrition, remember we talked about a bland, non-irritating diet choices. You're going to eliminate any coffee and alcohol, any cigarette smoking, things like that. And then the medications, we need to teach them to avoid which medicines that can irritate the stomach. In any aspirin, any of those over-counter medications. And then you have to assess their coping style. You know, remember that stress can cause flare-ups in peptic ulcer disease. And then you make sure that you that the patient has a good understanding of their treatment regimen so that they will stay well. Action alerts on page 1104. You're going to teach that patient who has peptic ulcer disease to seek immediate medical attention if they have any sharp, sudden, persistent, and severe epigastric or abdominal pain, if they have any blood or black stools, or if they have any bloody vomit. Also, you're going to teach the patient that's had surgery for peptic ulcer disease to avoid any over-the-counter medicines that contain aspirin. You're going to emphasize the importance of taking all of the H2 antagonists, the proton pump inhibitors, and the antibiotics for that H. pylori infection until it's gone. Okay? What questions or comments do you have about the peptic ulcer disease? This is the evaluation after the patient has been treated. They are free of peptic ulcer disease flare-up, and they're not experiencing any GI complications. Now we have a case study. The nurse is interviewing a client who reports abdominal pain at the meals for the past several months. The pain occurs often after eating or lying down to sleep. Over-the-counter antacids provide some relief. Which assessment findings does the nurse anticipate that increases the risk for development of a peptic ulcer? Is everybody agreeable with C? And that is correct. C is correct. Peptic ulcer disease is associated with NSAIDs, taking NSAIDs. While reviewing laboratory results, which value does the nurse identify that support the diagnosis of peptic ulcer disease? Select all that apply. What do the rest of you think? Okay, let's see. A, B, and C. That low hematocrit, low hemoglobin, and they're positive for H. pylori. An EGD confirms the client has peptic ulcer disease and the prescription for triple therapy is initiated. Which combination of drugs does the nurse prepare to administer? Answer is A. Remember the proton pump inhibitors, Prevacid, Flagyl, Biaxin. It'll be 2 antibiotics and 1 proton pump inhibitor. All right. As the client prepares for discharge, the nurse provides discharge teaching. What education does the nurse provide? let's see, A, C, D, E, okay? The client should avoid any spicy food because they will irritate ulcers and gastric tissue. All other teaching points are necessary in treatment of PUD and H. pylori. All right. There are some other questions. I will post this handout to your teams where you'll have it with the correct answers. So we have already determined what appendicitis is and what the cause of appendicitis is. Our next question about appendicitis is, how does the nurse know that the patient may be having an acute infection in the appendix? Okay, and that's where this picture is showing here. This is McBurney's point. And if you palpate on the opposite side of McBurney's point, then you would have symptoms of abdominal pain on the opposite side. So like if you palpated on the right side, you would still feel pain on the left side where the appendix is. So palpate on the left side of the abdomen, and you're gonna have pain on the right side of the abdomen if you palpate on the left side. That is the main clue that maybe that person has appendicitis. Another clue is going to be rebound tenderness. Who wants to come up and demonstrate rebound tenderness? How to assess for rebound tenderness? Everybody's looking away.
It's always here.
You too.
Me too.
Yes. You all are a pair. Demonstrate how to assess for rebound tenderness. Come right out in front of you. So right now, show us how you all have been assessing the abdomen.
Okay, well, we start with auscultation first, so I need to go through that? Okay, so assessing all four quadrants. All right, and then we'll take and palpate. So let them know if they feel any tenderness or pain whenever I
Stop making it weird.
And so you would still do that, and now we're gonna add rebound tenderness.
Okay.
So where you were pressing and going all over the abdomen, now you're gonna do this. You may start here, press. When we lift our hand up, and I'm exaggerating that hand, but when you press down firmly and lift up, it's going to be excruciating pain. That is rebound tenderness. Thank you.
Good job, you guys.
That's how you demonstrate rebound tenderness. Now, what are going to be some significant lab findings for appendicitis? What's going to be significant? Elevated white blood cells
With a shift to the left.
with a shift to the left. So what does that mean, with a shift to the left?
An increased number of immature white blood cells.
Okay, so those neutrophils are going to be high because they are been sent out to help fight off inflammation and infection. So there's going to be an increase in the neutrophils. As you said, a shift to the right, left. Why do I have? It's what you said, a shift to the left. I see it. Okay, so that's one way of determining if someone has findings for appendicitis. The palpation of the abdomen, where the pain is elicited, and then you're going to be looking at the lab. One important study that you're going to pay attention to is the ultrasound, because the ultrasound will show that enlarged appendix. If you think that they may have some type of fecal-like stone obstructing the appendix, then they can go and get a CT scan, and this is going to reveal the presence of a fecaloma. And an MRI will show images of the appendix to see what's going on with it. Now, what is non-surgical management for this patient with appendicitis? We're going to keep that patient NPO. If we suspect that they have appendicitis, keep them NPO because they need to go right away to surgery. We're going to control their pain. We're not going to be giving them narco-PO though. We're going to keep them NPO and give them IV medication. So we're going to give them IV opioids, maybe some IV NSAIDs. That's what we're going to be giving, and also antibiotics to treat their infection. That's the non-surgical management. Now the surgical management is, of course, we've held that patient NPO. Once we determine that there's definitely something going on with the appendix, maybe it's perforated or a very hot appendix, then they're going to do an appendectomy. And the way that it's going to be done is through the laparoscope. They're going to go in and make the 4 little small cuts and remove the appendix. There's another way that they can remove the appendix is by a transvaginal endoscopic type procedure, where they go into the vagina and make a small incision to enter that peritoneal space and remove the appendix. Or they can do it the old-fashioned way, where they do an exploratory laparotomy, and this is an open surgical approach with a large abdominal incision. Remember, they're just exploring. They don't know what they're going to find in the abdomen. What they think may be an appendicitis could be something going on with the large intestines, so they'll be able to see exactly what's going on in that abdomen area. Okay? If complications such as peritonitis or an abscess are found during that open approach type surgery, this is where the patient will have wound drains inserted. They may have an NG tube inserted to decompress their stomach and prevent a lot of abdominal distension. And then, of course, they're going to receive IV antibiotics and the opioid analgesics, and you're going to be helping to prevent post-op complications from occurring with the patient who has had laparoscopic surgery or the exploratory lap type procedure. What complications will the nurse be trying to prevent after surgery? Pneumonia, abscesses, abdominal distension, constipation, wound infection, DVT, peritonitis. So you're going to be looking for all of those things, assessing that patient, especially if they have the open lap procedure done. So you're going to monitor for complications, for abdominal infection and those abscesses, and you're going to be monitoring them for any bleeding through any dark stools occurring. And you're going to provide that post-op care that you learned in first semester. Okay? What questions or comments do you have about appendicitis? The questions that I put on here did not say.
What is the
two exemplars that we're not gonna be doing.
We're doing all of them.
I thought you said.
We're doing 3 today and 3 tomorrow. There are 6.
No, you said, okay, 2 of, which one?
All right. What questions or comments do you have about appendicitis? Okay, I will reload the appendicitis with the NCLEX practice questions on there so that you will see them, and then we can review them quickly tomorrow with the answers. But let's talk about cholecystitis. This is the gallbladder disease. This information can be found in your Iggy MedSurg book, page 1177. All right, so what is cholecystitis? Inflammation of the gallbladder, and that inflammation can be either acute or chronic, and the inflammatory process is going to oftentimes affect that patient's nutritional status, where they will have a decreased appetite, or eating foods is going to cause him to have a flare-up. Now, there are 2 types of acute cholecystitis. There's a calculous and an acalculous cholecystitis. And what that means is there's ones where there are gallstones and one where there is not gallstones obstructing the gallbladder. Okay? But whenever the gallbladder is inflamed, there may be trapped bile that's reabsorbed and acts as a chemical irritant to the gallbladder wall. And instead of it draining through that bile duct on into the small intestines, it is obstructed in some way. So patients that have gallbladder problems will oftentimes have gallbladder problems. They will have liver problems because of the obstruction of both of those coming down the bile duct. And that's what this picture is showing here. Can you see the gallstones? And you see the portal vein? And you see that if gallstones obstruct it, then the liver cannot function properly like it should, neither can the gallbladder. And then what's going to happen to the GI system as a whole? Malabsorption may occur. Instead of the stool being a brown color like it should because bile is being able to be drained through it, the stools are now pale, but the urine is real dark. So you'll be seeing symptoms like that in your gallbladder patients, as well as patients that maybe have liver dysfunction going on. Again, if that gallbladder perforates or ruptures, what does that mean for your patient? Peritonitis, an overwhelming infection. Okay, so what is the difference between acute cholecystitis and chronic cholecystitis? Chronic is going to be caused by repeated episodes of that cystic duct obstruction. And the gallbladder, after repeated episodes of being inflamed, it will become fibrotic and atrophy, which will cause decreased motility and deficient absorption by the gallbladder. Okay. What are some risk factors for gallbladder disease on 1178? What are some risk factors?
Women of all ages, American Indian, Mexican American, or Caucasian, obesity, rapid weight loss, or prolonged fasting, low-fat diet, increased serum cholesterol and lipids, and women on hormone replacement therapy.
Okay, so those are some risk factors for it. As well, if you're on a cholesterol lowering drug like a statin, if you have family history of gallstone, if you have prolonged total parental nutrition infusion, that can cause risk factors for gallbladder disease. Any gastric bypass surgery, sickle cell disease, pregnancy, glucose intolerance, all of that can be risk factors for cholecystitis. There is one patient-centered gender health consideration. Your classmate touched on it some in saying that obesity is the major risk factor for gallstone, especially in women. A lot of times they will attribute the 4 fours to risk factors for gallbladder disease. What are the 4 fours? The bottom of 1178.
Female, 40, fat, and fertile.
Yes, female, fat, 40, infertile. Some of us may not appreciate that, but those are some risk factors for gallbladder disease. Okay, so when you are assessing the patient with suspected gallbladder disease, what does the nurse need to be sure to ask about in the history?
Their diet.
Their diet. You're going to be asking about any food preferences, because what do you know will contribute to gallbladder dysfunction and disease?
High-fat diet.
High-fat diet, especially if it's excessive in fat and cholesterol, then this is going to cause some GI upset for the patient. Diets high in fat, high in calorie, low in fiber, and high in refined white carbohydrates place patients at risk for developing gallstones. So you need to ask about what type foods they are eating. And then we need to ask questions about what type GI symptoms do they experience when they eat a fatty meal. Do they have flatulence, which is gas in the lower GI tract? Do they have dyspepsia, where they have epigastric burning sensation, that gnawing, boring type pain that's oftentimes referred to as heartburn? And do they have eruption? What's eruption? Eructation. That's where they're belching. And if they're having anorexia, nausea, vomiting, and abdominal pain. So you're going to be asking these questions for your gallbladder patient. What symptoms would we expect the patient with gallbladder disease to complain of? Mostly abdominal pain. Okay, it may range from mild, persistent ache to a steady, constant pain, but it will be located in the right upper abdomen, right underneath the liver, as that picture showed. One thing about gallbladder pain is that it will radiate a lot of times. Where does it radiate? Right shoulder or scapular. So if it's radiating to the right shoulder or scapular, then you can very well believe that it's probably some gallbladder disease. Okay? There is a critical rescue block on page 1179. It shows that that severe pain that the gallbladder patient is feeling is called biliary colic, and it's produced when there is obstruction of the cystic duct of the gallbladder, or it occurs when there's movement of some of those gallstones. So when a gallstone is moving through or is dislodged within that duct, then the patient is going to experience some tissue spasms. And this biliary colic may be so severe that it occurs with tachycardia. They may get pallor, become very diaphoretic, may prostration where they're extremely exhausted. It can put that patient in shock. Biliary colic can be so intense that they develop shock. So in the past, they have had to call rapid RRT to respond to some of these patients, because you don't want to overlook that it could be a cardiac issue. But you stay with the patient and keep the head of the bed flat if shock occurs. Some of the other symptoms that you're going to be looking for, besides that epigastric pain in right shoulder, or scapular pain, or maybe some biliary colic, is that you're going to still see rebound tenderness. And again, if you push their abdomen deeply and then quickly release that pressure, if there's pain, then that lets you know there's some peritoneal inflammation. Okay? Now, in chronic gallbladder disease, you may see that patient with jaundice, because remember, the gallbladder is tucked underneath that liver. So if the ducts are blocked in any way, then you're going to see symptoms from liver. You're just going to see some liver dysfunction, and this is going to be jaundice. Where will the jaundice occur?
First noticed in the sclera,
In the sclera,
mucous membranes.
the mucous membranes. You may see clay-colored stools instead of the dark stools, dark brown. The urine will be dark, and this is from biliary obstruction. Ictus or icterus is the same thing as the jaundice, where you will see yellow discoloration. Steatorrhea is going to be the fatty stools from malabsorption occurring. And again, your book says fatty stools because of fat absorption is decreased as a result of lack of bile. Now, what are some key features of cholecystitis at the bottom of page 1179? And we've talked about all of these. As a reminder, what are some of the key features?
Episodic or vague upper abdominal pain.
Okay,
Anorexia.
flatulence, the pain will be triggered by that high fat or high volume, high calorie meal, steatorrhea, the jaundice, clay colored stools, dark urine, fever. Okay, now what lab results are going to be significant findings for someone with gallbladder disease? Your liver enzymes. All of the liver enzymes will be elevated. And if that pancreas is involved, then you're going to have an elevated amylase and lipase level. What are some other diagnostic tests you would monitor as they're ordered? The physician has a choice to do a KUB, that's just a plain abdominal x-ray that will show the gallbladder. May do an ultrasound of the right upper quadrant. That's the best initial test to be done. If all else fails and they still suspect that it's gallbladder disease but nothing is showing up, the HIDA scan will be done. And this HIDA scan can visualize the gallbladder. It looks at the duct system and evaluates the function of the gallbladder. Okay? The only thing is doing this HIDA scan, the patient must lie still. Another test that is done is this endoscopic retrograde cholangiopancreography test, the ERCP. This is an old test, but you'll still see it done. Or they can do a magnetic resonance of that same test to look for gallbladder dysfunction. Okay? But what is a contraindication for any MRI testing?
Iodine, if they're allergic to iodine.
If they have any metal in them.
Oh, I'm looking at.
Okay, any metal or incompatible devices, they won't be a candidate because it'll pull that device out of it. The magnet is so strong. All right. Now we're going to look at management. How will the nurse manage pain? What medications would you expect to give the patient with gallbladder disease? Toradol and Dilaudid, or they may give the ketorolac, which is the same thing as Toradol, but that ketorolac, I want you all to know that that is Toradol. They will give that to manage pain. Now, there are some bile acid dissolutions or gallstone stabilizing agent. This is like the Ursoldeol, is what your book says, and the Chino oil. I know I'm not pronouncing that correctly, but you'll see it at the bottom of 1180. There are two drugs. And these drugs will help dissolve or stabilize the gallstones. What's another test if the medication is not effective in dissolving the gallstones? What's the next procedure? Extracorporeal shockwave lithotripsy. And this procedure can be used only for patients who have a normal weight, cholesterol-based stones, and they have good gallbladder functioning. There are several videos on YouTube that will show this procedure done. Still another treatment that's non-surgical management for gallstones is the insertion of a percutaneous transhepatic biliary catheter. They will insert this drain using a CT or ultrasound guidance to open that blocked duct so that the bile can flow out. You'll see that done as well. Now, the surgery for gallbladder disease is just like the other ones that we've talked about. It can be laparoscopic, where they make the 4 little incision. This is the gold standard for removing the gallbladder. They also could do an open procedure, and you don't see this done often, but they can do an open surgical incision to remove the gallbladder, and it's going to be just a long scar in the upper right quadrant of the abdomen. Now, after this patient has had surgery, how does the nurse take care of this gallbladder patient that has returned to your floor? You're going to be treating the pain with medication, and it'll probably be IV medications. Turn, cough, and deep breathe to prevent pneumonia. Medication for nausea, such as Zofran, if they're having something for, if they're nauseated.
Incisional care.
Incisional care, you expect to see the inflammatory process, the redness, a little bit of swelling, but it should not look like infection is still present. It's going to slowly begin to heal. So you're looking for incisional infections. Early ambulation, you don't want them to get DVTs or anything like that. And again, teaching them about follow-up care with their provider. When to return for the surgeon to look at his work again and see how the wound is progressing. How soon can the laparoscopic surgery patient leave? Okay, sometimes within the same day. They may instruct them to rest for the first 24 hours and then to gradually resume their activity. Okay. The traditional gallbladder procedure is found on page 1182. And remember, we said anytime that they go in and do laparoscopic work, if they find something, and they will find something with that gallbladder, if it's packed full of stones, gallstones, or if the ducts are obstructed, then they're going to have to go in and remove and fix all of that. So you can expect that they're going to leave some T-tubes for drains, for that area to drain from inside of the body. You all know that anytime that you have a surgical procedure that's internal, in order for all of that drainage to get outside of the system, it has to have a drain left in there for it to drain out of the body. So if it's a traditional open cholecystectomy where they remove the gallbladder, then you're gonna be taking care of the T-tube drainage that's in the common bile duct. You have to make sure that it's draining. If it's not draining, then it could lead to liver dysfunction for the patient. So how do we promote nutrition for the patient with gallbladder disease? What kind of food are they going to avoid? Avoid high fatty foods. Do you know some examples of high fatty foods? Fried chicken. And hamburgers and things like that. What should they be eating? High fiber, low fat. So you want to know some high fiber foods, low fat foods. Avoid eating any gas producing foods. Small frequent foods. They can eat those instead of 3 regular meals a day. All right. What questions do you have about gallbladder disease? Okay, we have some questions, practice questions that we're going to go over now.